in the comments. Hi, how are you?
Hi, how are you?
So nice to chat with you. For those of you guys who haven't met Dr. Master, you don't know his background and credentials, can you give us a little bit of a bio about you?
I just like having a good time, really.
He's just a good old guy down from
Down
Australia.
under, yeah,
Under.
yeah. We're here for a good time, not a long time, as we say. Um, I guess I'm a obviously a doctor, MD, as you call it in the United States. In Australia, we call it an MBBS, Bachelor of Medicine, and Bachelor of Surgery. So it's two components that we do. And then I went into surgical training for some time and did a lot of surgical sort of periods and residencies, and then went on to doing basic surgical training. And then I decided to go to the dark side and became a radiologist and specialized in radiology. And then over the last, it's been 6 years or so at least, that I've now started doing aesthetics. And the way I got into aesthetics is because I report the varicose veins, which is still part of aesthetics, I guess, isn't it? Because it's looking at varicosities and skin changes in the legs. And I report the veins and incompetencies, etc. And a friend that owns a practice here in Melbourne, he said, you should start looking into this. So long story short, I ended up starting to I started injecting, learned my tox, started my fillers, and then I got some requests for some people that said, oh, I know the had an MRI and had a bit of problem with her eye. That was the first case. And after that, basically, I started getting more and more requests, and I started integrating ultrasound into my practice. And now imaging is an integral part of my practice, everyday practice.
Amazing. So I think that people around the world know you most from your MRI studies that show that filler in the tear trough and other areas can last as long as 4 years, up to 7 years. Can you kind of summarize some of your research and how much MRI imaging have you done and what is it really showing?
Yeah, so the paper that was delivered, it had approximately, I think it was 12 to 14 patients, because I'm doing a lot of other papers as well, so I can't remember everything off the top of my head, but the vast majority of those patients did present with puffiness in this particular paper. Puffiness around the eyes is the most common complaint, and basically 8 of those 12 patients still had evidence of filler despite not having or not giving us a history of any filler injected 2 years prior. So a lot of these people showed that their filler was still there on MRI. Had a post-septal complication, i.e. it was under the eye. For those who are watching who aren't injectors, it actually went behind the little septum that divides the eye to the back. And she was also one of the 3 patients that I wrote up on the second paper in Plastic and Reconstructive Surgery of America, which talks about the complication of getting filler inadvertently behind the eye. So they're the papers that have been written up. I've got another paper I'm writing up on my own face with a colleague here in Melbourne who injected my face a few times with a stack of different types of filler, but the last treatment was 4 mils of one particular product. It was a Restylane product, and we've got some interesting findings, but I can't tell you what that is. All I can say is, surprisingly, in one area of the face, it completely dissolved, almost completely, but in the other areas, it stuck around. So this is going to be a very exciting paper as well. And then I'm
Wait, you're
writing
not
up.
going to tell us the reveal? You're
No,
not going to
I
give it
can't.
a little
No,
bit?
no,
Just
no.
10 people that are 15 people are listening right now. Unfortunately, my other Instagram got blocked for community guideline violations because I posted about toxic masculine portrayal of women in aesthetic surgery, and they blocked me for showing the male postings. So
Oh,
paradoxically, so that's why
yeah,
we're here on my modern aesthetic platform. So
I see.
hopefully people will tune in here, but I really think you should give us a preview of what's good, what that article is going to show.
I, I can't give you too much, but what I can say is that most commonly, and I've scanned, I think, over in the last 2 years at least 110 patients exclusively for MRI of the face and created a
Okay.
protocol for that. So I've seen a lot now, and I've got a reporting template now as well. So the reporting
Interesting.
template actually has Upper
I feel
face,
like you should
face.
share that with, we should share that. If you send it to me, I can share it with injectors everywhere, because I think one of our biggest problems is we don't report to the filler companies when we have filler migration, long-term filler duration, or, problems with the filler. We just deal with it and take care of it as clinicians. But the more we
Mhm.
report, the more likely that the more they're compelled by the FDA to do further studies.
Yeah,
Um,
that's right.
I think it would be great. How many dissolving filler procedures are you doing on patients? Has it become a regular part of your daily practice now?
Yes, it is. So I'm at a public hospital 3 days a week, and I'm doing injectables only once a week. But that's a long day. Sometimes it's 10 to 12 hour day, and in that day, I think about 25% of my practice is dissolving under ultrasound, and at least 1 to 2 of those cases would be MRI first to find where that residual problematic filler is, and then using the ultrasound to guide for my depth, because ultrasound doesn't necessarily find that filler that's really integrated into the tissue. And that's again another paper that I'm going to be working on as well with my colleague who's a master's in sonography. He suggested that we should follow one patient, virgin face, and ultrasound and MRI, and just keep doing follow-up imaging
Serial
and
studies.
and just show when does it disappear on ultrasound and when does it disappear on MRI, which I don't think it ever will on MRI, because MRI's contrast, water contrast, is just dynamite. It's unbeatable.
Now, what kind of protocol do we order? Like if I'm in Los Angeles and I want to order a facial MRI to look for filler problems, am I going to order an MRI with contrast, with any special facial weightings or?
Yeah, so I've actually passed on the protocol because I did some. I had a scholarship at USC at Keck School of Medicine, so you can
Mhm.
send them across to Keck in East LA, and they should have my protocol. I've passed it on to them. So USC is the place to send them across at the Keck campus in East LA, and they should have it. So basically, the protocol is without contrast. You don't necessarily need contrast. It's the protocol is actually set out in my publication. It's got it written up there. So if you even need to sort of tell them clearly what protocol you want, you can even quote on your request form. You can even quote my article and say, PRS article, blah blah blah, or give them a call and let them know. And it's written in plain language. The technicians will clearly know exactly what to scan and exactly where to look to find that stuff.
Now, in the tear trough area, there's a lot of controversy and people talking about not wanting to inject tear troughs anymore. Like I know the guy from Australia from the Victorian Institute, is it Gavin? Yeah.
Gavin Chan, yeah, he's
Yeah.
interviewed me a few times as well. Yeah.
So what are your thoughts about just not even doing tear trough filler? Do you feel that because fairly soon we're going to have FDA approved products for the tear trough through Galderma, with Restylane finally getting approved, and I think that that's going to be difficult because novice injectors are going to be excited about treating this area, and we're going to have filler deposited where it shouldn't be in some cases. And then very long term, according to your studies, it can last 4 to 7 years in the tear trough.
That's right. Uh, Look, I think it's like anything, isn't it? You're going to get a better result when you have expert injectors performing these kind of procedures. And I think the candidate is most important, as you would know. You need a good candidate. If you've got significant skin laxity, you've got poor skin coverage, you've got a lot of, and potentially, I guess, the age group as well, which is quite important too. I think you're going to be more likely to have problems, and your depth and your volume is going to be an issue too. So
Yeah.
I'm not against it at all. I do tear troughs, but I try to do as much as I can outside of tear troughs first. So, for example, laser, you can look at Q switch for pigmentation. You can use high frequency ultrasound around the eyes for skin tightening and collagen regeneration, etc. Try to do all these things first, and then come back to me, and we will consider using a small volume of the appropriate product and nice and deep. And of
Yes. And
course, controlling the orbit. So I actually put my finger on here and hold down the orbital retaining ligament, and make sure that it just stays in there, because the SOOF is a very small space underneath that orbicularis.
And how do you prevent post-septal injections? So you're identifying sometimes filler that's caused bloating, puffiness, and problems, and it's actually been placed post-septally, which is very risky and very difficult to reverse. How are you, what in your technique helps prevent that besides pushing the ORL?
I just use, in terms of, the anatomy, making sure you identify the ORL, make sure you don't go above that orbital rim. I think that's the key, that you identify exactly where that orbital rim is. And you make sure that I press very, very firmly to make sure that it pushes up against, the ORL, but doesn't go over the top and superficially. I don't use a cannula because I've got the benefit of scanning beforehand. So I look at the infraorbital artery, make sure there's no little branches or any naughty vessels sort of passing around here. If there isn't, then I just mark it out. And if I know that the depth of the infraorbital artery, where it is, and if it comes out here and it starts going into the, usually it comes into the mid-fat component just underneath the SMAS, around the mid area here. If I know that it hasn't come out too early or where it has come out, I generally just know that I can undermine the vessel. So if it's not too deep and it's already come out, I can go underneath it. And I do use needle because, yes, we feel that needles are a bit higher in risk, but if I've got the benefit of ultrasound, I find the accuracy of needle is far greater. I don't know whether you feel the same way.
I love a good needle, but it only takes one infraorbital bruise and the patient will tell you the rest of their life about that time you gave me the black eye.
That's right.
And then they'll be
That's
so
why you got to find that vein and artery.
Yeah, like that one. I go with needles for a few weeks, and then suddenly I get a big old black eye, and then I'm back to cannulas for a while. Yeah. But I'm a big fan of surgery. Since I'm a surgeon, I'll do under-eye blepharoplasty when necessary. I think that, like you said, there's some key components to patient texture and tone and laxity. What identifying characteristics have you found in patients when you're doing these MRIs that maybe predisposes them to get puffiness and bloating or filler retention?
Well, the vast majority though, not all of them, are over 45, around 45. That's the age group. The skin laxity that we talked about. They were the people that were probably the best candidates to have. They're better off having a bleph, as you said, much better off. So the vast majority of those cases are the older age group with significant skin laxity that probably should not have had trough injections done in the first place.
Right.
I think they weren't really candidates for it, and they might have got a good result initially. And then often I see these cases after about a year, they said it looked great for 1 year, and then they start getting the swelling and the malar edema, and then they start getting superficial, infraorbital fat, which is superficial fat, edema and swelling as well. And I think there's also a contributor, which is misplacement. So yes, they might have injected deeply, but that there might have been a superficial component of filler already there, but it was masked. And then after a period of time and degradation of the product, more attraction of water because of the degradation of the product and the molecules, then the swelling manifests itself. And often those cases, I don't even necessarily need to do an MRI. I just do a superficial sweep in the infraorbital fat, leave the SOOF, don't touch the SOOF, and you can let them walk away happy, and they still have not had their tear troughs returned. So I'm going to be posting one of those cases on my Insta that showed just a beautiful demonstration of just superficial chip away of a small volume of hyalase.
Yeah, I've seen people do that. Do you have any filler preferences in this area? This is a very common question for injectors. Like, what are your favorite fillers to use in the infraorbital area? Which ones retain water the least on MRI studies? And yeah, what's your answer to that?
At this stage, I don't have enough answers because we've got so many different products, so little history as well, that we can't work out what is the biggest culprit. So I've only got some anecdotal things, but I don't want to sort of name names as such. I'm a bit fearful of naming names. Look, what I can say, and you can probably work out what product, really super cross-linked products are the ones that stick around and can cause problems, especially in the tear troughs.
Yeah, the Vicross technology is the most
I would
problematic.
not use Vicross around the eye. Do not.
Which
I
is
would.
interesting. Allergan is apparently training and saying that it's acceptable to use the thinner Vicross, like Vovella and whatnot, in that area. But I think it's highly dangerous because it's very difficult to get rid of. It's such thin skin. It's like
Mm.
a world of problems when it doesn't sit right. When it sits right, it looks good, and I've tried it there, but it's like difficult to reverse.
Yeah, and is it worth it? You know, I think a lot of injectors like to sleep at night. We all
Yes.
sleep at night, so why put yourself in that position? I do like this product, and everyone raves about it. I don't know whether you have Redensity too, the product by Tiozl, I think you call it there,
Yeah.
Tioxane.
And Teoxane. So in America, it would be the RHA family of fillers by Revance. Yeah, we don't have that yet. We have RHA 2 and 4, which are different
Yeah.
versions of that. But I've heard that Redensity is very thin and lovely, maybe like more like Bellaterra, which we do have here.
Mm. Yeah,
Yeah.
Redensity is very forgiving, and it comes up a treat, and it doesn't look obvious. You know, it's subtle, but it still
Yeah.
has a result. Um, haven't I'm just wondering if I had to ever get rid of it. I don't think I have as yet. But the product, unfortunately, you know, the history that we get from patients often is quite difficult too. So, you know, people aren't going to remember everything that they've had. So we need a decent study that follows and starts now and goes for quite a few years with all these different products in the same location and
Mm-hmm.
image and in live people, which is very different to cadavers. Because I think up
Yeah.
until now, I've been playing around with cadavers. And when I started and I was going to conferences and all that kind of stuff, they threw up the CT now and then. And I'm thinking they need to really image people live, like the real people,
Mm-hmm.
what's actually
Yeah.
happening in the face, you know?
I think those are the most significant studies that, and the studies that when you publish the MRI findings, it's just kind of flabbergasting to see, because clinically we've suspected all along when we see people back 3, 4, 5 years later and they have a blue Tyndall effect, and you're like, but the filler was so long ago, but you can still see it. And now this is actual physical evidence on the MRI that there's still retained break product there. Do you think it's breakdown product? It's the gel filler that's broken into its component molecules. It's just lingering and not processed by the lymphatic system? Or is it encapsulated? Is it in the wrong plane? Is it the injection technique?
I think this is, again, not scientifically based and anecdotal at the moment, but my feeling is that the areas that have a combination of poor movement or little movement and poor lymphatics. So, and also as you age, everything ages, and so does lymphatics. So, around the eye, as we're learning, there was a recent paper that only had one patient, but they injected some dye and followed the lymphatic pathway, and it goes across and then down from the orbit, right? So, there isn't
Mm-hmm.
a great drainage plan. If you've got a lot of filler in the cheeks, in the deep medial cheek, or in the SOOF, etc., or the lateral SOOF, that can potentially either damage the lymphatics or obstruct the lymphatics from draining the fluid down. And as the rheology of products, I believe, is that as they break down, they do attract more water and are more hydrating. Then it's a combination of all those factors. Plus, as we know, for example, when you walk, your calves are squeezing your lymphatics and the veins. That's the only way that all the fluid comes back. Otherwise, you end up with edema, right?
Mm-hmm.
So, in an area around the eye, other than the orbicularis, you're not going to have much kind of giving this area a squeeze to get rid of it.
Right.
Whereas the lower face tends to, you know, move around. And I've only had to dissolve a nodule around the masseter once and something else, I think, in the chin area, and that was it. And an ischemia around the chin area. That was it. Otherwise, I haven't really had to do much. It seems to be focused in the mid face.
Mm-hmm. When patients have malar mounds and malar edema, or that, kind of the deep zygomatic ligament indentation, do you have any special words of advice? And how does that show up on MRI? Are you seeing that as a fat compartment that's superficial, that's filled with a lot of water-based volume?
Yeah, well, look, what happens is the zygomatic cutaneous ligament tends to, the filler actually follows that pathway and just sort of lingers along it. that
Yeah.
stripe. It's like a stripe almost, and that's a very
Yeah.
very common appearance. You just see all these patients with this kind of, and I think in my publication one of the articles is a coronal, and it shows that kind of linear appearance following Langer's lines and following the ligament, the zygomatic cutaneous ligament. So that's a very common appearance. I'm not sure why, but I guess it's a retaining ligament, and that's why it's just holding there and just sitting there. So that's very common. But to kind of, I mean, what I'm doing, which is something that I've been doing recently, and it's been working so far, is actually doing some fans superficially in multiple compartments and starting at the anterior border of the masseter. And it's superficial, so I think these fans of HA tend to pinch and maybe give a little bit of tethering of the skin. And I
Mm-hmm.
found that gives it a pseudo kind of liquid facelift, I guess. I'm finding that is more successful now than just repeatedly filling the cheeks, because most people, or a lot of our clients, we can't just keep filling the cheeks.
Right. You
So
can't. I get very, even if you start to climb laterally, it starts to be abnormally broadened in here.
that's right.
Yeah.
And that superficial stuff would be easy to get rid of if you need to get rid of it at some stage. And I think part of the take-home message I would like to give to injectors in this discussion is that we just have to respect filler and realize hyaluronic acid filler, that it could stick around for longer than we expect. Expect to manage that filler at some stage, and be suspicious when someone comes back with puffiness somewhere and go, well, this could be the filler that I placed and it's manifesting itself in another area. Not that it's moved. I'm not sure about migration now. The new evidence, I'm about to publish another article on 28 patients exclusively in the mid-face area, 28, which is a good number.
Mm-hmm.
So at this stage, the majority of the evidence, including even on my face, it doesn't show that it moves, it stays in the same spot. It just must have gone to the wrong place at the time of injection. That's my
Yeah.
mantra at the moment, but I think we need to prove that.
I think my theory, I do feel that as injectors, when we inject these gels, they come out as cohesive, beautiful strands. They're exactly, roughly where we place them. But as the filler breaks down into breakdown products, definitely you get so much more areas, surface areas of the hyaluronic molecule. And each, of those 6 surface areas of the molecule absorbs 10 times its weight, 1,000 times its weight in water. So I think that the breakdown products actually are what are retained, and they're processed by macrophages. So in some patients, when I've used Sculptra, which brings in foreign body reaction and macrophages to process the Sculptra, they also are the cells that gobble up the hyaluronic breakdown products. So I almost use it like a scavenging technique, which goes in and cleans up. At this point, we're seeing patients who have 6 to 10 years of filler upon filler and different stages of degradation and breakdown. So I love your idea of looking at serial studies and tracking each filler to see what its behavioral properties are radiologically, because we actually don't even know, other than animal studies that have only been watched for 1 year, to make these fillers become FDA approved for facial treatments. So that's kind of my theory, that it's the filler breakdown products that are accumulating and spreading and drawing in 10 times more of their water weight, because so much more small cleavage molecules of long chain hyaluronics. But who knows? Who knows? I think.
That does make sense. And I think, as you said, the breakdown products and the fact that it does, I can tell you at least there is some sort of a diffusion process where it starts flattening a little bit. It doesn't spread a long distance. It
Yeah.
just starts flattening and becoming less defined. You don't have this beautiful linear thread anymore on
You don't.
MRI. It just starts becoming a bit hazy. And as
Yeah.
you said, as it breaks down, that linear thread probably didn't attract that much water when it was well defined. Once it
Right.
starts breaking down, even though it might be less than half a millimeter wider than before, the amount of water that attracts could be up to a centimeter.
Yeah, definitely. And
And
that's
that's
why
why
we
it
have
matters.
our lip filler ladies come in and ask for very precise lip borders, just like the last time. And you're like, well, I can't do that anymore because now it's softly effaced by this, gel breakdown. So talk a little about lip filler. So have you done any studies with lips to show how long filler lasts? Is it really truly causing this migration?
So lip filler again, you know, and in the publication I did write whether it's migration or placement. They were the two questions that we were asking: migration or placement. And I feel that I haven't actually done any studies. So at this stage, my main imaging was ultrasound of patients looking at lip filler, and this is again not scientific, but my daily practice has shown that a lot of the time I see filler up here, and it's lateral for some reason.
Yeah.
But my feeling is that it was probably injected into the least resistance, which ends up being above the lip and the vermilion border, because as you fill that lip, the bottom lip not so much, but as you fill the top lip, as it gets fuller and fuller, it becomes more difficult to fill that top lip because of its limited space, and then it ends up just passing up above the lip at the time of injection, and then you end up going, well, look, it seems like this is going to be, you know, a bit of swelling or something like that, and it will resolve, and then it doesn't end up resolving, and then it's still there. So I think that's what we often feel is migration. I feel that is probably going to be what's called you know, placement at the time, but inadvertent. You're not sure, because it kind of makes sense. Once you've got a limited space, it's always going to go into an area of least resistance, isn't it?
Definitely. And in terms of liquid rhinoplasties, I do a lot of those. I thought it was fascinating because we had discussed previously that thought you can still see filler within the nose several years after injection, not just 1 year. It's a small amount of micro droplets that we're placing and theoretically only lasts a year, but actually you see it much longer.
Mm. So yeah, sorry, so I missed that again. You cut out a bit.
I think you had told me that you have seen filler in noses from liquid rhinoplasty for longer duration than a year. Can you elaborate on that a little?
Yeah. There was about 2 cases. I did see one that actually dissolved. So it's not, again, we can't say all in medicine, and this is really important. And I think there's some people on YouTube and etc. who are trying to scare tactic everyone. Not all fillers last forever. It's very, very important to know. And we did do a case, had a look at it. It was, you know, suspected filler from 2 or 3 years ago that was put in the nose, and it was gone, completely gone, right? I don't know what the product was exactly. This other product was a friend of mine who was included in my study. So she volunteered, which is very nice of her. And she had, I think it was Vicross product, just on one side of the nose, just to straighten out an indentation. And that was over 2.5. It was I think it was 2012 or 13. It was like it was 6 years old or 7 years old at the time.
Wow.
So study was 2019. So 6 or 7 years, and it was still clearly there. Just a nice little white dot, just bang, right there.
Yeah. I mean, that's my impression after doing 4 or 5 years of liquid rhinoplasty, that when I see people back at 18 months, even 2 years, they never go back to their original nose. They really truly have retained some change in their original architecture. So I think with 2 or 3 sessions, this could almost become a semi-permanent look for some patients. So that's kind of a good place for filler longevity. We talk about it like it's a bad thing. Maybe it's a good thing in certain areas. Yeah.
Particularly because it's not going to cause too much swelling and all that kind of, you know, it's not going to cause too many issues.
Yes. Do you have any tips for patients about maintaining filler longevity in areas where we don't want it to diminish quick?
Well, I think the focus of most people is often around the eyes, isn't it? Around the orbit. That's the first thing that people notice around in aging. They get upset about the orbital stuff. And I think if you're over a certain age group, don't take them in terms of injectors. Don't chase the money. Don't take the money. Just say, look, I think you're better off with the blepharoplasty. Or if there are options, as we talked about, laser or high frequency ultrasound, regeneration, collagen regeneration, the creams, obviously you must prescribe a lot of skincare.
Yes.
Which is critical as well. But I would maintain the filler by observing your photos. Clinical photos are critical. And I think the problem is people forget what they look like. And they look at their earlier photos before they had filler. Then they got a result after they had filler, maybe a year or two after. And then they keep getting these top-ups and getting bigger and bigger and bigger slowly. And they don't remember. And if you go back to that very first photo, and after 5 years of having so many injections, you'll look back at the first photo and go, wait a minute, I actually looked so much younger if I went back to, even though it is, you're still younger at that age, if you dissolved a lot of that filler and then refilled in the areas that are wanted, you'd find that the patient will be a lot happier and their face will look slimmer and they'll look a lot healthier. So a tip that is a practical one for the injectors is what I do is I often draw a line from commissure to Traeger's, and it depends on how much volume they've got in that buccal fat pad, but I do a linear thread of dissolver around there just to get that cheek shape back, because often, you know, inadvertently, as you're injecting the cheeks, it can go further down into that buccal fat pad. And I don't know whether people realize that when you're actually injecting around here, you're probably in the buccal fat pad, and there's a superficial temporal fat pad along here as well, as you know. So I try to dissolve along that area to try to get that OG line back. I'm not a fan of nasolabial injections. Piriform's fine, but nasolabial folds in the actual fat itself, again, these areas that have been treated, I think as soon as you inject it and you smile at the time, it just goes straight into the nasolabial fat and it makes it heavier.
It does.
I don't do that area at all. I think that was very trendy 10 years ago, wasn't it?
Yeah, it's fascinating. I think the more I see dissolving patients every single day, and I like your idea that maybe we have to do facial resets on our patients that have done filler for 10 years and recontour them and dissolve
yes.
them.
And you'll find that it does work. It does work. So I did it along here, and I think now my wife sort of watched. I used to practice on her many, many years ago, and she goes, "You need to get rid of this. I think there's some here. Just keep getting." So she asks for dissolves along there, because the reality is that inadvertently, you know, and after you've put a lot of volume, which she doesn't have at all. I just did some practice as well, but because she's watched so many videos, she's paranoid that there might be something left in there. It's all gone. Along here, you know, I'm sure that some might find its way there. Nasolabial fat, maybe inadvertently, small volumes have found their way in there. Even when we inject the piriform, I've been guilty of it, you know, that I've injected the piriform and I put an ultrasound probe on there, and some of it I hadn't quite punctured through the septum here of the nasolabial fold. And I think some of it ended up in the nasolabial fat, which makes things worse. So I had to dissolve that little bit in there.
Yeah,
so
I think it's so important as an injector to be critical to your own work, but to be kind to yourself, to realize that this is an art and it takes adjustments, and it's okay to dissolve, and we have to give that vocabulary to our patients too, so they don't think we've done something in error, that we're just adjusting. You know, just like an outfit needs alterations, the face needs alterations.
Well,
So
it's sculpturing. So when you sculpt, you actually add your putty, but then you also scrape away the unwanted components. Is that right?
That's right, the scavenger effect. And building foundation, are you using collagen biostimulators like calcium hydroxyapatite or Sculptra in your practice?
No, I haven't started using those yet. I guess it's just the fear of God in me. I'm quite conservative.
That's like a whole new revelation.
I don't even do liquid rhinoplasties or glabella areas. Too fearful. But I think it has to be on the cards with ultrasound guidance eventually. Yeah. Particularly the temples. I would love to do those under ultrasound guidance. What layer, for example, in the temple do you prefer? Are you going up against periosteum?
Always against periosteum. I think that's the safest, the deepest layer, and I'm on bone, I'm on periosteum. I think that's easy, and I really don't think that there are periosteal vessels that are significant enough And I'm
Mm.
still aspirating. I'm still a believer in aspiration, even though everybody's published articles about how it's not effective and it's definitely not foolproof, but I do aspirate there for sure.
Mm.
So yeah, temples is like the fountain of youth. I think the more we build the temple, the more we get that fullness of the upper face and lower face taper. I also think that just encouraging weight loss, like you said, we forget what we used to look like, but 10 years ago, we also had like 10 pounds less body weight. Like uniformly, adults, as they get to be 40 and 50, all put on like 7 to 10 pounds of extra weight. Shows
Mm.
and patients sometimes come in looking thin and gorgeous and younger. They look 10 years younger. Like, what'd you do? And it's like, oh, I lost 15 pounds. Like, okay,
That's all it
that's
takes.
really,
That's all
it's
it
important.
takes.
It really, you do need to also tell your patients that, like, I lost weight and I even myself feel like, oh, I have cheekbones again. So,
Mm.
so I think, giving realistic parameters of what filler can do is also super important. Do you have any
Mm.
specific proportions of Hyaluronics or dissolving agents that you use in terms of like the amount of gel filler and the proportion of dissolver that you use?
Well,
I don't think that,
it depends on what I'm doing. If I'm doing it for an ischemia or an infarct, I only use about 30 to 50 units of high lays. So I'm not sure what that equates to with Hyaluronics. I think the units are very different. But if you use the old technique where there's an ischemic, say, facial artery, they would use a whole vial of hyaluronidase, which is 1,500 units every few hours. You remember that technique?
yeah, yes.
So, I think in the future is in every, I think, local area like Pasadena or, for example, in DTLA or somewhere, there should be at least one person who's quite good at ultrasound who wants to perform that. I don't think ultrasound necessarily has to be integral in everyone's practice. You're highly successful without using ultrasound with your anatomy, your plastic surgical background, etc. And I think injectors need to be quite well versed in their anatomy, and also not to be overconfident, as we said. Know your limitations. I think if there's someone we can call in the neighborhood and go, hey, I might have an ischemia, then they can use the ultrasound and only use 50 units, and they maintain their filler. So you find the obstructed artery. So that's 30 to 50 units, sometimes maximum 100. So, for example, if superficial, the very infraorbital fat, very common issue that I told you about, I would use usually 50 to 100 units. So the formula that I used is a paper I read, it was about 2 or 3 years ago. For each, say, 0.1 mil of filler, you use about 30 units of hyaluronidase. So that's a conservative formula. Once you struggle, then you start having to introduce things like steroid. So I use Kinacort A10 and
Mm,
1 milligram per area for, say, 0.1 or 0.2 mil of filler with the hyaluronidase. And the hyaluronidase, I always add lidocaine, 1%.
yeah.
And I add water so that it has a bit more retention, sterile water rather than saline.
Interesting.
So it doesn't dissolve away. Water means that it's going to stay in that area. It's not isotonic. So you want it to stick around a bit longer.
Well, that's pretty genius. I didn't even think of that. I love that idea.
Hmm.
So yeah, just sometimes you want water bloating because it'll stay in the tissues a little longer there. I think I'm doing something similar. I probably use about 10 units per 0.1 cc's. I'm under treating with Hyaluronic
Yes.
because I've seen a lot of patients who've come in like fully over dissolved to the extent that it's excessive, I think.
Oh, the trough comes back and that's a disaster.
Yeah.
Start
And they're
again.
really happy, then you go back for the refilling and they're
Yeah,
still like they're hollow. So I think it's important to soften the filler versus erase it fully when we can. Yeah.
100%. They might have to come back a couple of times, of course. It's a management issue, but they would
Yeah,
rather do that.
definitely. Well, I think I agree with your thoughts that ultrasound does not have to be in everybody's practice. There's a push sometimes for a new trend for everybody to hop on it, but I can't read ultrasounds very well. I need a radiologist to help sit with me and read them. So if I ever have an occlusion, I'm going to do what you say, which is kind of going to someone who's an experienced ultrasonographer and sit with them, help them like find the spot and inject right then and there under
Yeah.
visualization. I think that's key because if I'm going to look at those black and white waves. I don't know if I'm going to see everything I need to see, you know.
And it's extremely rare. The other thing is, in ischemia, you know, it happens to everyone. It will happen at some stage. Otherwise, you haven't been injecting enough. But we have to be able to manage it. But it's rare. It's extremely rare.
Yeah,
So, you know, the purpose of having a scanner just for that would be a bit excessive.
I agree. I agree. Well, in terms of MRI studies, what future studies are you planning? And I'm so excited to read these upcoming ones that are coming out.
So I'm just about to submit another one to PRS with my face. So it's following my face over a period of 27 months, which is great. And we
Wow.
know exactly where we injected and what we injected and what dates. So that's going to be a really interesting study, and that's got some nice reveals. The only issue is that it's one patient, but it's a start. The other one is a continuity or continuation of the study that I did with my 12 patients, showing longevity and suggesting MRI protocols to follow filler. I've added another, 18 or so patients. So we're up to about 25 to 30 patients. But then I've narrowed down those patients to looking at the tear troughs and the cheek. And
Mm-hmm.
then it's going to be fully tabled with hasn't had filler for 2, 3, and over 5 years. I'm
Interesting.
going to categorize it into a nice statistical table, and we'll have some sort of stats at least to provide, and it'll be exclusively just the mid face and cheek area. So that's why people have to be careful. It's skewed towards an area that I feel is an area of longevity.
Sorry, lost you for a second there, but I wanted to show people some pictures of these images, which if you haven't pulled these articles are super fascinating. You can see with the white highlighted areas, for example, here and here. Do you remember this picture? And you can tell me
Mm-hmm.
this. Yeah. So
Nasal folds.
the nasolabial folds very long term, and it's just kind of fascinating to me that we're able to identify so clearly, like this is evidence in the under eye and this is in the post-septal area with fat injection, filler
Yeah.
injection right into the fat, and you wonder why dissolver is not reversing it.
So
So I think we have
the
some
top
really
picture there.
awesome tools, and very innovative thinking coming all the way from Australia. And I can't thank you enough. I know you only had about half an hour to spend with us today, so thank you for
Yeah.
going over it.
Thank you.
Yeah, you're invited to come to LA. I didn't know that you trained at USC for a bit. That's my alma mater. I love USC.
Yeah. No, it's a great campus, and I miss the weather in the States. But currently with what's happening right now, yeah, it's hard to travel. I'm just going to wait for Omicron to sweep. Omicron gone, and then I might come out.
Yes, maybe I might see you at AMWC in Monaco. Would you travel to that in April coming up?
April might be a bit hard with the twins.
Oh, that's right. You have young twins. How old are they?
4.5 months, 5 months.
Oh, congratulations. Did you have a boy and a girl, or what did you have?
Two girls.
Two girls. You know, I have
Yeah.
a boy and a girl twin also. I had them in my chief year of residency. I don't even know how I survived that year,
How did you do that? I am amazed. Hats off to you. I've had to take off so much time, and there's two of us, and we still struggle.
oh, we struggled. We had to move in with our in-laws, and it was a lot. I didn't sleep for a whole year.
You're a resident as well. That's hell. That's really
It
hard.
was, yeah, it was hard, but they're grown now, so you'll get there. This is the
Yeah,
fun
we'll get there eventually, and hopefully, they won't be asking for filler too soon.
Well, congratulations on beautiful new family.
Thank you.
And for those of you who don't know, you got to Google Dr. Mobin Master, who's also a fabulous techno DJ. What's your DJ handle so they can check you out?
Oh, it's just Mobin Master.
Yes, he's actually quite famous. I looked him up and he's got like millions of followers for one of his accounts, and his music is really hot and happening.
Yeah,
So,
check it out if you like to. But you
well,
can still
thanks so
trust
much.
me. I'm a doctor.
Well, you're talented in many areas. Where can people find you or send you questions if they want to reach out, get more info on your MRI protocols?
So the best way is to go via aestheticradiology.com.au.
Okay.
So
And
aesthetic radiology, I've got a website and it actually shows the stuff I do, and it shows the clinic I work at and the technology that I use as well. And it just gives you a hoedown of aesthetic radiology. And soon we're going to have a few other aesthetic radiologists around the world where I'm going to stay in touch with them, and we share cases and learn from each other and can provide a service to the injector. And hopefully there'll be one based in every single state or every single town, so that not everyone has to have ultrasound or MRI skills, etc., that we can actually provide a service to you.
I think that's amazing. A whole new subspecialty of radiology, and we need it. Aesthetics is growing like, you know, crazy. It's wildly popular in the States, and we need the safety to go along with the new techniques and things we're pioneering. So very innovative. I love it. That's it for now, guys. Thanks so much for tuning in. Don't forget to find me on my Instagram. It's Beauty by Dr. K. And you're currently watching us on Modern Aesthetic Theory and Artistry. That's my online platform right there. We teach injectors from all around the world. We have about 27, 28 different modules, everything from beginner basics with Botox to fancy things like liquid rhino and Sculptra for the face and Sculptra for the butt, all the fun things that you need to learn. That's it for now, guys. Thank you, Dr. Master. We really appreciate
Thanks
all
for,
that amazing knowledge and innovation.
thanks for
Take
having
care.
me. Yes.
Love you. Bye. Bye, guys.